Now, Arvind is going to look at the checklist, but I need 5 or 6 quick mentions here. Justifiable indication, relevant recent images in place, meticulous surgical planning done preoperatively, valid, informed, legally acceptable consent, a psychological profile too late to assess but should have done it, and you have equipment and personnel in place. Now, why is this important? We'll go ahead. So positioning is the bedrock of a surgical intervention success. And let's look at the 4 issues that you shouldn't forget. Associated pressure point issues, access and ease of surgery, equipment compliance, and neurovascular traction or compression. These are 4 things that you have to look for. So a goal, as usual, is to maintain patient's airway, avoid constriction, pressure on the chest cavity, maintain circulation with good abdominal freedom, prevent nerve damage, provide adequate exposure as a surgeon, and make it safe for the patient, isn't it? So let's start prone. 8:15, you're wheeling in the patient. Suddenly, you realize your fellow is around. There is an OT assistant and the anesthetist who is intubated and said, "Chalo, patient ko ghumana hai, 118 kilos." And invariably, that's the time the OT assistant will say, "Hello, hello, hello, bol, nani position karto hai." He disappears. 120 kilos kaun uthayega? A smart fellow will probably say, "Sir, 1 minute, I'll just come." And he disappears, and then you're left with nobody. So the key is to have every personnel in there, because this needs a certain plan. Imagine this patient is going to undergo a cervical myelopathy surgery, and you are left with 1 assistant and 1 sister to do it. Unpardonable. That's your problem. Get the personnel in place. And then you look at all the things there. The headrest in place, the hands not getting too stretched for traction palsy, good protections at the iliac, good protections at the femoral areas, the knee and the hip at good flexions, the foot not in contact with the operating table. This is all your onus, because the patients come for you, not for the OT assistant or the anesthetist. So I think for the younger lot, this is where you take the chance. The same thing applies in supine. If you're going to do an ACDF, you want some extension, isn't it? So the roll towel has to be in place, and that has to be organized before. You also need to see to it that your shoulder needs to be strapped down, isn't it? Because the cervicodorsal junction is where the problem is. And most times you're struggling to see imaging at that area. So strap it, not at the fingers as it was done many years ago. You could have skin peels in the fingers, if I remember right. Do it at the shoulder and let it get pulled. That's the area of concern. One of the OT assistant puts your ECG lead somewhere, where that's where you're going to be operating. Who's going to see it? After draping? No way. You're going to do an iliac crest bone graft. It was never prepared. Who's going to see it? You. Because the onus lies in all of you all. The lateral, much less used now. All the principles remain the same, but remember, the rib to the iliac crest on the side of where you're going to approach has to be well exposed. The onus ends in you. And I think what I want to convey is, most times as you get senior in the circuit, you want to believe things are in place, but every 5th case, just look around what's happening, and you'll realize there is some error happening there. Every 5th case, make it a point, and this is for all, even the seniors. 1 in 5 cases, just go a little early and see what's going wrong. So what can go wrong? Pressure point sores. Literature talks about 5 to 60%, mind you, but nowadays it's gone down to about 8 to 11%. And this is one of my experience. 6 weeks of turmoil. Why? Wonderfully done scoli, all well aligned, but immediate post-op inframammary abrasion, and that went on to become an abscess. 6 weeks, the relative, the mother, had nothing to ask for. She's completely forgot the scoliosis point, but inframammary abscess was a concern. Why? That not there. So you did about 3.5 hours of surgery, overlooked this, and that caused it. What about this? Patient came for a very good microdiscectomy, and patient goes back with this kind of sore. I don't think it's justifiable, is it, in this? Subungual hematoma, everybody laughs when I say it. I had a patient of my own, diabetic, lumbar stenosis surgery done. The foot was on the table, bent down there for a long time. It actually became a hematoma, converted into an abscess, led to nail removal. Imagine the extent it went, and that was just a 1-level decompression and fusion. iPad, I know Ram's going to talk about it. Hemodynamics plays a big role, but position equally does. So remember that the eye pressure has to be kept, and a 10-degree angle reverse Trendelenburg helps always. Let's look at ease and access of surgery as a surgeon. Let's somebody with this thick neck, and you want to do a posterior cervical decompression or instrumented fusion, obviously strap him down and get the straps in place. Get us something which is really strong, something like a dynaplast as against a small white chikat patti that you stick, because by the time the fellow scrubs, that chikat patti is already loosening out. And it's important because that's where your access lies. More so important when you're going to doing something like an occipitocervical fusion or something. So this is very, very important that you strap him down. Or the lumbar surgery. We've heard it from so many times from the senior that position him in such a way that you get reduction in the lordosis, increase in the L4-5 space, so your access is better. Simple things makes your life easy. Or you're going to do an odontoid screw, and he's a fat, big, or a big, huge man with a huge chest who does a lot of gym activity. Biggest problem is access, isn't it? So position the patient in such a way that your trajectory for the odontoid screw is well defined, because a poorly positioned can either end up poor alignment or you can end up being mal-placed screws. Unpardonable, isn't it? Because of an axis. Ang-spawn is a totally different ball game. So in a kyphotic deformity with an ang-spawn, remember that you will probably end up even breaking the table. Who's going to take the onus? You as a surgeon. What about equipment compliance? You came into the OT, position was almost being planned. Just before you were turning, you realized there is something wrong. What's wrong here? For the fellows out there, you can't do an AP view. Can you do an AP view for a lumbar fusion here? Who's going to look after that? You'll realize no. Now, as a great surgeon, you must say, I don't look at C-arms only. It's all my hand of it. That's fair enough if you're good enough for that. But if you want an AP view, you better see to it that that's in place. And you have to have your equipment compliant positioning. The last part, again, is a lot of clutter around, a lot of instruments open, implants, sets open. Your table gets pushed onto one end of the corner of the whole room. Anesthetist is in some other corner struggling with everything, and your lights don't reach where you want to reach. And therefore, light and magnification are important. Please see to it, if you don't have this in place, make yourself independent, which is have a headlight and a loop in place. In a tandem stenosis, there are a lot of teams working, a cervical group, a landum group, and it's very important that there is a cautery wire which is the opposite, the cervical end which is with you and the lumbar end at the cervical. Have a diagram in place for your fellows or OT assistants so you know where each of the things are positioned. Makes life much easier. The Jackson is ideal, but do we have Jackson everywhere? No, you have to make up with what is available. And please remember that simple things like this is what we do at the Mathadi Hospital. This is actually the foam that came with the C-arm parts, simply used almost for 6 months. So you don't tell me because you don't have Jackson, you've had a sore or a iliac sore. Head rings, enough in the market, but constrained innovation. If you don't have it, basic head ring, use a gloves, good quality gloves with water in, and tie it up. You can even use it for your cervical spine. So just because you don't have stuff, when you practice and go out in the nursing homes to do, you should not compromise. And neurovascular, whether it's lymphatic drainage being affected, the chest or the diaphragm excursion affected, or pooling because of abdominal pressure, all this have to be looked for. Over-enthusiastic OT assistant or an OT technician might pull your hands away. You can end up with brachial traction palsies or meralgia parasitica because you have cluneal nerve pressure at the iliac crest. Or in one of my seniors I know had a femoral nerve palsy post-op because of severe pressure. Again, unpardonable here. 2 extra last slides here. Peripheral pumps are important because that's your heart outside. They have to be in place. And last but not the least, warming blankets. The man who made the blankets said it's a wonderful invention, but it increases the risk of infection. Why does this happen? Is because you put the blanket was somewhere lying in the corner next to the toilet, you bring it in and you put it in between the legs, nobody drapes it, the scrub is happening by the fellow, he scrubs intensely for 5 minutes and he goes away, the blanket is still on. Who looked at infection there? So sterile it, cover it well, strap it down so that the blow doesn't go into the area of the wound because infection is a problem. So all these are your checklists in your positioning. And remember and don't forget, use safe body mechanics to transfer patient with enough equipment and personnel in place. Before draping, check on the adequate access for surgery, especially something like the odontoid screw. Neurovascular, chest, abdomen and diaphragmatic exertion, beyond which eye needs to be given priority. And equipment around the operating table should be placed for ease of use, and cross-check all of this before you actually start draping. Thank you very much.